Good afternoon, everyone. Welcome to another installment of the Humanities at the Heart of Healthcare, or H3 webinar series, proudly brought to you by NHG Health Group Clinical Education in collaboration with the Institute for Humanistic Medicine, or HUME. Our tagline, Real Talk for Real People for Real Practice. My name is Aaron, Director of HUME, and I'll be your host and moderator today. Modern medicine is remarkably good at classifying people and things. We diagnose disease, stage cancer, quantify risk, and sometimes we categorize patients as either having capacity or lacking it. But human beings rarely live in binary. Many older adults inhabit a gray zone where memory fades, reasons fluctuate, and understanding depends on time, as well as relational factors like trust and support. In these moments, the challenge is not simply to determine what patients can no longer do, but to discover what they still can do and how we, together with families and caregivers, can help them do it. Supported decision-making represents more than a legal or ethical framework. It is a different way of seeing the person before us, not as a problem to solve, but as a person whose voice remains worthy of listening to. And this is the conversation we are inviting you in today. Before we begin, let me say a few words about what we hope to achieve through our H3 webinars. At HUME, a central pillar for our learning activities is not to be didactic but dialogic, not to be instructional but to allow for reflection. Therefore, our goal cannot be to hand you another checklist, algorithm, or protocol. We cannot offer neat answers to the complex and often messy questions that healthcare professionals face every day. Instead, at H3, we want to create a space to pause in the midst of your busy clinical work. And I guess this lunchtime will be a good time to pause and reflect on this, to examine familiar problems from a different perspective, and to reflect on how our professional values are translated into the realities of practice, where trade-offs are inevitable, values sometimes conflict, time is limited, and there is rarely a single right answer. So if you leave today's webinar with a few new questions, a little intellectual discomfort, and perhaps a renewed sense of curiosity and inspiration, we would consider the time you spend with us well spent. Because the wisdom rarely emerges from certainty, it grows through thoughtful dialogue, honest reflections, and professional humility to keep asking what truly matters. Before I introduce our speaker and discussant, just a few housekeeping points. This is a MME-eligible H3 webinar. Clinicians who log on and engage for more than 80% of the webinar can qualify for 1 MME point. The format today is a 30-minute talk by Esther, followed by a 10-minute reflection and discussion by Michael, and then 15 minutes for Q&A. We love this to be a conversation, so post your questions and comments in the chat throughout the session. We'll address as many as the questions we can during the session, and if we run out of time, we will endeavor to respond to the questions after the webinar. At the end of the sessions, we'll be grateful if you could complete the feedback survey. Your feedback is important for us to improve our activities at HUME. And if you do like what we are offering, please sign up for our mailing list. Now, it's my pleasure to introduce our speaker and discussant who will bring us through navigating the gray zone, supported decision-making for older adults in the margins of capacity. Esther is a senior consultant geriatrician at Tock Hospital, head of Cognitive and Memory Disorder Service, deputy chair of the TTSH Clinical Ethics Committee, and recently completed her Masters of Bioethics at the Harvard Medical School. Today, she will be sharing her capstone project or her thesis on supported decision-making for older adults at the margins of capacity. On a personal note, I have known Esther since she was a geriatric medicine resident. It has been a privilege to watch her grow into a thoughtful clinician, ethicist, and leader. What began as an early interest in mental capacity and ethics has become a sustained commitment to advancing shared decision-making, an area that is central to HUME's work. It is also particularly gratifying to see the next generation taking on this work. Now, Michael is the Director of Education at the Center for Biomedical Ethics at the Yong Yulin School of Medicine, NUS. For more than 2 decades, his scholarship has explored the ethical and legal dimensions of decision-making within adult caregiving relationships spanning family life, professional care, and the courts. His work has shaped thinking on relational autonomy, supported decision-making, and ethics in everyday clinical practice. On a personal note as well, Michael has been part of the Hume story almost from the very beginning. Back in 2024, when Humanistic Medicine Institute was just more than an idea, was just little more than an idea, we took a leap of faith and cold called him for advice. To our delight, he not only agreed to meet us, but also generously accepted our invitation to serve as one of Hume's advisors. His encouragement, wisdom, and generosity of spirit have been tremendous gifts to us, and for that, we remain deeply grateful. So today's topic is about decision-making in the elderly. I can't think of anybody else better and more qualified to discuss this than Esther and Michael. So thank you so much for joining us. And with that, I'll hand the time over to Esther and we can begin.
Thank you, Dr. Ang, for the very kind introduction and for the opportunity to come share with you all about my capstone project about supported decision making for older adults in the margins of capacity. Can everyone see my slides? Should be able to, right?
Yes.
Okay, great. So we only have 30 minutes for this talk, and there's a lot to unpack with regards to supported decision making as well as capacity assessments in the older adult. So without much further ado, I'll just jump straight in. So the agenda for the talk today, we are going to talk about capacity as a continuum and what decision-making, supported decision-making is, why guardianship is a last resort. We'll talk a little bit about clinical practice integration of using supported decision-making, what are the challenges and safeguards, relational autonomy in the Asian context, particularly in Singapore, and then I'll end with some key takeaways. So I hope that at the end of this talk, the learning objectives would be achieved. So number one, you'll be able to distinguish between supported decision-making as well as shared decision-making. Recognize that there is a gray zone commonly encountered in older adults. Thirdly, to understand the concept of relational autonomy and decision-making capacity. And lastly, we're going to discuss about applying supported decision-making principles within the Singaporean context. So why does this matter now? We know that Singapore has an aging population, and because of that, there's also rising cognitive impairment, right? So as populations age, prevalence of dementia and mild cognitive impairment rises. Now, more so over with the recent disease-modifying therapies that are available for the treatment of mild cognitive impairment as well as early-stage dementia, you can imagine that there will be more patients who live in this marginal capacity zone. So there's a substantial share of older adults that live in this gray zone of capacity that binary all or nothing capacity tools fail to capture. And a lot of these patients, in my experience, in my engagement with them, they wish to remain involved in their own decisions for as long as possible. And they would not want to, hand over the control of some of these decisions outright, even to their loved ones. In Singapore, families already increasingly sort of provide this informal decision support already, but there's often without a organized or recognized framework to help guide them do this properly. There is also demand in growing for autonomy-preserving alternatives compared to guardianship and full surrogate decision-making. This is evident in the patients that I see in memory clinic, where sometimes they get referred to us to assess whether they have decision-making capacity and whether we can evoke guardianship for them, even though the patient's cognition may not be that poor, right? Now, really the call to action now is that we should look at this clinical window to plan ahead while capacity is still intact, because if we wait too long, then after that window of capacity to act early would be missed already. So I'll start by sharing a clinical dilemma, which is very common, and we often encounter this in geriatric medicine or in most of the medical practice that we have here in Tock. So Mrs. Tan is an 84-year-old lady, and she has mild dementia. She was recently admitted to us after a fall, and other than that, she had been relatively well. And so now she insists on returning home after hospitalization. Her only son lives apart from her and works full-time, and his own family to care for. So worried about her falls and whether she will fall again and being home alone, he's asking whether we can place her in a nursing home. Now, we tried to talk to Madam Tan about this. She understands there are some risk to her going home alone, and she may struggle with more complex decision. So the question I pose to you now is, do you think she has capacity? And if she doesn't, who should decide for her? And I hope that this can help you realize that actually it isn't that clear. So why is traditional capacity thinking inadequate? So historically, we think that it's only two ends of a spectrum. Whether patient has capacity, okay, then patient decides. Or if patient lacks capacity, then someone else decides. Usually it is a family member or a physician, right? However, capacity is not a light switch. So it's not like something you can flick on and off and it's binary, right? So we know that decision-making capacity can be dynamic. It is time and decision specific. A lot of things can, affect a patient and their ability to make decisions. For example, whether they're unwell, their medical conditions, the kind of support that they have, and the environment that they're in, right? So many older adults with cognitive impairment actually exist in this marginal capacity zone, where they are neither fully capable nor fully incapable. But our legal and clinical systems often impose a binary has capacity or lacks capacity determination, ignoring this liminal space, right? There are many examples we can talk of that has this problem. So this binary approach can actually lead to overprotection, where we strip the patient of autonomy unnecessary, or is under protection where we leave the patients without much needed decision-making support, and that can potentially cause harm. So I would like to propose a thought, right, where we look at decision-making capacity as a continuum, and you really look at it like a sliding scale model, whereby you look at one end of the spectrum or the sliding scale where patients have full capacity and these patients can decide independently. Then the other end of the spectrum are the patients with no capacity, where they require surrogate decision-making that should be made in their best interests. Now, life is often messy, and in reality, often, it's not so clear-cut where they have or they don't have. So what about those patients in the middle who are not black or white and really in this gray zone of marginal capacity, right? So they usually either need some support, especially in the early stages of cognitive impairment, to help them make a decision, or as they slowly sort of gear or veer towards more impairment, then they need more substantial support before they eventually reach this part where they are unable to make decisions despite the support that we can give them in the discussion. So that's why I would say that most of the older adults, at least I see in my practice, lie in this middle or gray zone. So in the decision-making continuum, most of the time when we talk about independent decision-making, the key things we look for are that these patients who have full decision-making capacity, they are able to understand, appreciate, and can communicate the decisions independently. There's no need for any external support for them to make voluntary and informed decisions, right? So these patients can make decisions autonomously without assistance. Now, on the other spectrum where they need surrogate decision making, these are the patients who are not able to make specific or all decisions independently. And so guardianship legally transfers this decision making authority to a surrogate. And this is often a last resort due to the risk of overprotection, stigma, and loss of autonomy. So a substitute decision maker makes the decisions where the individual lacks capacity. But what about in the middle, where we talk about supported decision making? It really acts as a bridge for those patients whose capacity fluctuates or is limited but not absent. So supporters, right, they help to interpret this information, communicate options, and maybe clarify preferences with these beneficiaries or patients. And this really helps to preserve the individual autonomy by enabling them to make their own decisions. So the deliverable from the supported decision making is that these individuals with marginal capacity are able to make decisions with assistance from trusted supporters, right? Okay. Now, why do we say that guardianship should be a last resort? Because there are four things that we need to consider. Number one is the anti-therapeutic effects. So guardianship can often lead to social isolation by removing opportunities for the individual to participate in decision-making, increased feelings of loneliness and exclusion. Stigma associated with guardianship may also result in diminished self-esteem as well as well-being. It is also a one-way ticket to dependency because once we've sort of like decided that we impose guardianship onto these patients, right, it is very difficult to reverse even if the patient's capacity improves or fluctuates. And this permanence can actually foster like learned helplessness and dependency, limiting opportunities for regaining decision-making autonomy. And one thing that we always look at when making decisions for patients is that it should always be of the least restrictive alternative, right? So in a way, guardianship, tends to replace all decision-making rights, disregarding that least restrictive options that preserve it. And ethical and legal doctrines actually emphasize that we should always use least restrictive interventions necessary when we want to do decision making for the patients. And lastly, it's a very blunt instrument because this lack of nuance can lead to overprotection where capable decisions are unnecessarily removed and underprotection where some needs remain unaddressed. So marginal capacity is common among older adults with cognitive impairment, so therefore require more flexible, individualized approach rather than blanket guardianship. So in terms of defining supported decision making, it is really a cognitive prosthesis for autonomy. So the key features of supported decision making are as follows. In an adult with marginal capacity, or we call the beneficiary, they should be able to freely choose to engage trusted individuals, aka their supporters, who assist in making and acting on their decisions. Right? So the supporter acts as a cognitive prosthesis, right? An extension of the patient's agency by helping them with understanding, So sometimes in a medical consult, right? They come with them to the medical consult, and then as the doctor sharing information about decisions that have to be made, for example, anticoagulation, maybe long-term care planning, legacy planning, etc., etc. The supporter, right, comes with them to understand what has been communicated, helps them to maybe simplify it such that it's easier to understand, communicate, and the decision execution, but without taking over the decision making. Right, so they sort of support the patient in making the decision. So this supported decision making actually preserves the beneficiary's autonomy by keeping them as the ultimate decision maker, unlike surrogate or guardianship models where decisions are made for the person. Now, supported decision making is distinct from surrogate decision making, whereby another person legally or formally makes decision on behalf of someone who lacks capacity. Now, supported decision making model actually respects the individual's rights and acknowledging that they may need help, but that doesn't mean that they lose the right to decide for themselves. And this approach really aligns with the ethical principles that emphasize respect for autonomy, dignity, and least restrictive intervention. So who can be a supporter? When we want to build a support network for a patient with marginal capacity, of course, we need to find someone who's trustworthy. Most of the time in our local context, supporters can be people like family, friends, former colleagues, rarely, but that has happened in some of my patients, which is like neighbors or professionals that patients knows and trusts, and they need not be relatives. So really, in patients who have family members, they may defer to their spouse, their oldest son, a trusted daughter, child, etc. But I think really where this would really come in very, very useful are for the older adults who do not have any family. So they live alone, they don't have no family members, they're never married, no children, and there's not much people that they can trust in the community. Then really we think about, who would be appropriate supporter for them. And that professional role may need to step in, and that may be people like us, right? Now, the person themselves choose who supports them, and they can change or remove a supporter at any time. Now, different supporters can be matched to different domains based on their strengths, for example, finances, health, or daily living. Now, I always joke, right, that I mean, people who know me well will say that, when it comes to finances, Esther has no decision-making capacity because I don't know anything. So when you choose a supporter, you may want to choose someone with that strength. So for example, if the person needs help with finances, then they need to find someone who's very good with finances, right? Maybe has some background in finance or at least know what they want to do with money and at least help the patient. But then they may want to look at somebody else who has a little bit more maybe knowledge in terms of healthcare stuff, and then they may want to help them with decisions that pertains to healthcare per se. Right? Yeah, so the supporters can be matched to the different domains that the patients may need support in making decisions. Now, I think it would be wise to consider using a network of several supporters rather than relying on one single person, because that reduces the risk of undue influence and, of course, supporter burnout, right? And good supporters listen for the person's own values and preferences rather than imposing their own views or decisions. Now, I'd like to propose a practical model for supported decision making in older adults with marginal capacity. So really the three steps are, number one, step one, identify the domains where support is needed. Then number two, identifying the kinds of support that's required. And lastly is to establish a support decision-making agreement, right? So in step one, the key activities that we should do is to assess the areas where the older adult struggles to make or implement decisions independently. Consider the broad domains, which include healthcare, finance, mainly manage like government related stuff, insurance benefits, or even their day-to-day activities, right? And we want to engage the older adult and the relevant stakeholders to identify priority areas for support. Then in step two, we determine the nature of support required. So is it communication facilitation, or is it to interpret the complex information that is being conveyed to the beneficiary or the patient? So the support can include, for example, helping the patient articulate their values, preferences, as well as life goals to guide decision. And then consider building or maintaining the network of supporters or assistive technologies to augment that decision-making capacity. So the different supporters may come together and build on each other's expertise to help this patient. Then step three is to establish the support decision-making agreement. Now, in overseas, where in certain countries where they actually formalize support decision-making, for example, whether it is in the US, in Europe, or even in Australia, they actually do it through a formalized sort of arrangement, through a written or verbal agreement that outlines which are the supporters and what are their responsibilities. So it includes mechanism for regular review and adjustment of the support as the patient needs change over time. And this ensures that the agreement respects the autonomy of the older adult and preserves their right to make the final decision. So supported decision making can be effectively implemented through this structured sort of three-step approach that identifies the specific life domains needing support, determine the appropriate types of assistance, and then formalizes the arrangement with clear agreements and ongoing monitoring. This method will ensure that the older adult with marginal capacity receives tailored support that respects their autonomy and adapts to their evolving needs. So in terms of clinical practice integration, what can we as clinicians do? So there are practical steps for us to integrate supported decision-making into our day-to-day work. So really we need to elicit and acknowledge the patient's cognitive challenges openly to build trust as well as to set a collaborative tone. We may need to assess how cognitive impairments affect decision-making in specific life domains, such as healthcare, finances, as well as daily activities to tailor the support appropriately. We should consider asking the patient directly, do you know who will support you in making decisions? Alongside the traditional surrogate question of, if you cannot decide, who should we talk to? So we can identify this existing support network. Now, we should also encourage patients to reflect on quality, reliability, and the trustworthiness of their supporters to help prevent abuse or neglect. right? Usually if they identify like only one supporter, our concern is that there may be undue influence, there may be some form of exploitation, for example, because there's no other check and balances available to prevent that. So as physicians, we should remain vigilant for signs of abuse, neglect, or exploitation related to supporter involvement and intervene as necessary. So whether we need to escalate the case or, or triage what is really necessary for this patient. And then we reassess the appropriateness and effectiveness of the supported decision-making arrangement regularly, especially as the patient's cognitive capacity evolves over time and gets worse progressively. So when we talk about supported decision making, there are often a lot of challenges, but there can be also safeguards, right, that we can put in to help operationalize supported decision making. So in terms of risk of undue influence, supporters may exploit or unduly influence beneficiaries, especially when they are already having cognitive vulnerabilities, right? So they may want to, they may influence the patient to make certain decisions that may benefit them, for example, financially, right? So mitigation strategies include using a network of supporters rather than a single individual to reduce risk. And independent monitors and mandatory reporting mechanisms can provide safeguards against abuse and exploitation. In terms of transition planning, clinicians and families need clear indicators and protocols to transition from supported to surrogate decision making as the capacity declines. So there's a need for like regular assessments, reassessments of the decision-making abilities in specific domains, and this helps guide timely and appropriate transitions. So effective transition planning prevents any abrupt loss of autonomy and ensures ongoing appropriate support. It should also fit in with informed consent. So supported decision-making must align with established informed consent principles in clinical care. I think it fits in very beautifully because, as we said, right, capacity is a continuum, and informed consent. If you're familiar with, Drain's concept of capacity, right, and informed consent, actually they gel in very, very nicely together. It enhances the patient's ability to understand, appreciate, reason, and express choices with assistance from supporters. So clinicians should integrate supported decision making into consent processes to respect autonomy while ensuring comprehension. Lastly, with regards to relationship to shared decision making, supported decision making differs from shared decision making, but the two are actually very complementary approaches. There's a triadic communication involving the patient, the supporter, as well as the clinician. And that actually strengthens the decision quality and respects autonomy. So this collaboration will foster trust, transparency, and shared decision making in complex clinical decisions. So supported decision making requires balancing accessibility with protection against abuse through careful capacity thresholds, safeguards against undue influence, clear transitional protocols, and integration with clinical informed consent standards. It complements shared decision making by involving supporters in a respectful triadic communication framework. So what about relational autonomy? Autonomy. Why the person in relation reframes respect for autonomy? So now in the relational view sees the patient as a person in context. This is very applicable in the Asian context where we are often embedded within our family or familial relationships, community as well as social roles, and we never really choose in a context-free vacuum, right? So in particular, in the healthcare setting, like the relational autonomy that we have or the relationships we have is sort of, for example, like a doctor and patient role, or like allied health or nursing with the patient role. So all this play a part into relational autonomy. So both dimensions are coexisting and mutually supportive, not opposed, and good care holds them in balance rather than letting either dominate. So the practical caution is that overweighting the relational side can slide into medical paternalism and suppress the patient's own voice. Overweighting the autonomy ignores the family reality of Asian care. So I would like to bring you to think about how we look at Singapore and the Asian context in terms of family, filial piety, and the law. So family-centered decision-making and filial piety actually deeply influences care and decision support in Singapore and many Asian societies. And we actually foster this sort of informal or organic supported decision making within families, sorry, without like a formal legalized agreement, right? And we see that commonly in our patients and their families. Now, the Singapore Mental Capacity Act actually enables individuals with capacity to appoint donees under LPA to make decisions if capacity is lost, focusing on substitute decision making rather than an early stage support like supported decision making. So formal recognition or registration of supporters for individuals with marginal capacity still remains ambiguous, and this actually creates a gap between organic family practices as well as legal and clinical frameworks. So this gap really challenges clinicians and families to seek to balance respect for autonomy with protection from abuse in our culturally appropriate ways, right? So practical frameworks are needed to integrate this like familial roles with formal safeguards to prevent undue influence, exploitation, or neglect in supported decision making. And the clinicians ourselves, we can leverage on existing family involvement while educating about the benefits and limitation of legal tools like LPA to promote supported decision making. So if we understand how local cultural norms and legal contexts, then that was really essential for us in effectively implementing supported decision making in Singapore's geriatric care settings. So we come back to Madam Tan, right? The clinical dilemma. So how do we bring it all together and see how supported decision making can help her? So really what we want to do for Madam Tan is finding out what supports that she needs in the specific task for decision making. So is it that she needs decision support in terms of as her ability to care for herself deteriorates? Does she need someone to help her, and who would be the best person to help her, right? So identify who the appropriate and committed supporter would be. Right, and then so that this supporter may be able to help her to remain independent and to be able to still make her own decisions. Now, in certain cases, unfortunately, I think clinicians, we may ultimately have to be the one who leads the case or triages the type of support patient need. And this is particularly applicable to patients, for example, who supporters they may not be able to find a supporter, or there's very poor social support for this patient, right? Then we have to decide, to be the one who may have to help them make the decision, or for example, escalate the case, especially when we feel that the supporter is not doing the right thing. So I think really the question we need to ask ourselves as clinician is that, as part of good clinical care, as well as in the care of our patients, we will want whether we want to be involved in this sort of like care ethics or ethics of care for the patient. And the reason why we want to do this is really stems from Carol Gilligan's work in care ethics, where we want to do the right thing in terms of the relationships we have with our patients. So the key takeaways from my talk today really is to think about, I hope you've sort of understood why decision-making capacity is dynamic, and it exists on a continuum from full capacity to incapacity, with many older adults in this marginal capacity zone where they may have mild cognitive impairment or early stage dementia. So supported decision making really acts as a bridge for those with marginal capacity, helping them to preserve their autonomy and decision agency. We shouldn't, use guardianship as the easy way out or as the last resort, because it can cause stigma, dependency, and it's difficult to reverse. It should only be used as a last resort only after supported decision making has been considered. Earlier, I've shared with you a practical sort of three-step approach to help clinicians identify domains needing support and the kinds of support required, and how we may want to consider, in the Singaporean context, at this point we don't have, but whether we should formalize some form of agreement with the supporters. And I think truly that is a question that we may or may not be able to answer. Then in our day-to-day interaction with patients, the simple clinical question of who helps or supports you in your making of decisions about your own healthcare decisions, right? It's a powerful tool to identify and engage supporters in care. Now, in Singapore and similar Asian contexts, supported decision-making actually aligns with family-centered decision norms, but requires maybe some form of formal safeguards to protect against undue influence and abuse. So I'd like to end with this quote from Mahatma Gandhi, where we really look at the true measure of any society can be found in how it treats its most vulnerable members. And the older adults with marginal capacity truly falls within this group of patients who are vulnerable. And I do implore that for all of you who take care of older adults with cognitive impairment, marginal capacity, to truly think about how we can do supported decision making to help this vulnerable group of patients. So I thank you for attention, and I'm happy to take any questions later. You can scan the QR code if you wish for the references for my capstone project, and I'll take this opportunity to thank my department as well as my mentor for my capstone, Dr. Ang, for supporting me through my capstone project. Thank you. I'll hand the time over to Prof. Aaron. I think Dr. Ang, you are muted.
I was just saying, I actually didn't do very much of the work. You did most of it. And it's an impressive amount of literature and thought that you have put through with regards to this. Thank you for also keeping to the 30-minute. It was a lot of information and it's quite dense. I was checking the questions. I think people are still digesting the information, and therefore the references will be quite important. I will now want to hand the time over to Michael to give his comments and feedback and of course inputs in terms of what was previously discussed. Again, another ginormous task to do in about 10 minutes, so we can move forward in the Q&A part to try to answer some of the questions that were posed to the participants that posed even before this webinar. So over to you, Michael.
Thank you very much, Dr. Ang. It's a pleasure to be here, and an absolute honour to be able to respond to Esther's incredible talk and really interesting work that she's done on supported decision making. This is a personal topic of interest of mine, and I'll share some slides to organise my response to some of the claims that Esther made, and hopefully that will allow a more fruitful and expanded discussion between ourselves. Okay, great. So I've described my talk as a response to Esther's navigating the grey zone, but I want to think a bit about supported decision making in a Singaporean key. And I want to spend a bit of time reflecting on, I guess, the distinctive practical orientation of Esther's proposal and how that differs from perhaps a more paradigmatic legal future vision that supported decision making has taken on internationally. Because I think there's a really nice local calibration in the work that Esther has been suggesting. So just to give people a bit of a backdrop, internationally, supported decision-making is presented as an overarching regulatory and practice paradigm for rethinking how we decide for people in need of help. And it comes largely from a disability activist standpoint and human rights-based challenges to a different kind of set of regimes that we are more familiar with. So guardianship, traditionally, the idea that you have a guardian and that person retains almost entire full control over your life and the decisions made about it. But controversially, the supported decision-making paradigm also attacks and goes after the Mental Capacity Act and the idea of using capacity as a switch, like Esther said, between those who have decisional ability and those for whom we make substitute decisions in their best interests. The supported decision-making paradigm does not like substitute decision-making, and it wants to rid the world of Mental Capacity Act regimes that allow substitute decision-making to be part of the legal framework. So it goes after the FCA in Singapore, it goes after the MCA in England, where I'm from, and it looks for a different kind of support-based model. And there are going to be some issues around that when we think about what that means for the kinds of proposals we can put in place in Singapore, I think. But just to be clear, and in red here, the supported decision-making paradigm is against these kinds of presumptions. It's against the idea that when someone lacks capacity, we are justified in transferring the authority to make decisions to another party, be that a donee, a deputy or a decision maker, a doctor, anybody else who has that ability in law to make it. And it also disagrees with the idea of putting best interests as a principle to guide substitute decision making. And so what it replaces it with, and this comes about through attempts in the United Nations Convention on the Rights of People with Disabilities, is to give people the support they need to be able to exercise their full control and rights over their own legal agency and capacity. Now, important to recognise that in the international space, Singapore, whilst ratifying the UNCRPD, has not agreed to endorse Article 12. And it says basically, look, we want to retain our Mental Capacity Act and a substitute-based decision-making framework. But if we take the support paradigm seriously, what we do is we engage with this idea that the decisions, even for people who lack mental capacity, should be made by them on the basis of their will and preferences, as far as those can be known. And the supporter's role is to explain, interpret, and communicate that person's will and preferences. And that's taken to be, through support, even when a person lacks capacity, to be more autonomy respectful than the process of handing the authority to somebody else to decide on that patient's behalf. So two immediate concerns here. One is this kind of paradigm is not going to work locally in the round because we have to be able to work within, as Esther said, our mental capacity frameworks. We have to be able to accommodate supported decision making within an existing legal framework. And that's challenging because those two things are set against each other in these debates. And the second question is about where we locate support. And for Esther, that's in the marginal zone between those who have obviously not got capacity and those who obviously have. But it's important to recognise that this paradigm in the round applies to everybody, even those who have no mental capacity to make decisions. It just becomes more and more difficult to assess their will and preferences. So I want to think a bit about this idea of locating supported decision-making in the margins, as Esther suggests, people at on the edge of capacity. Now, there are, I think, two support problems in our existing approach of thinking about mental capacity-based decision-making, and Esther really nicely captured these. And I think this, for me, is the real meat and potatoes of our current worry with the approach that we take in Singapore. When a person has mental capacity, we are legally required to give them control over the decision. They're in charge of giving consent, making their own decisions. And it's an individualistic model of authority that comes through consent in that approach. But the truth is, when a person is on the margins, as Esther suggests, that person's vulnerabilities, because of their impairments, cognitive impairment, disabilities, etc., makes their ability to decide and act on the basis of their decisions far more complex than a mere assessment of their cognitive capacities. That just captures one moment in time where one decision is being assessed, but the entire process of making a decision, acting upon it, living one's life when one is in this marginal zone is not going to be determined solely by whether the person has the strict ability to decide or not. And so the real danger, and this has happened a lot back home in the UK for me, is that we leave people alone when they haven't got mental capacity. We withdraw support. And there is a real danger here that trying to respect their authority to make their own decisions risks becoming abandonment. But on the other side of the fence, as Esther suggests, we risk giving people too little support if they're on the brink of mental capacity or they lack it. There is no principled requirement in the MCA to require a person to be involved and to participate in decisions when they lack capacity. The requirement is to assess their values, preferences, wishes in a process of substitute decision making, where somebody else decides on the basis of evidence about that person. This is a non-participatory approach to decision making. And so the danger here, in opposition to the other side of the coin, is that the person's voice just becomes a symbolic evidence-based exercise. We listen to them simply because we have to gather evidence to make decisions on their behalf. And the support we offer them is the mere act of substituting a decision for them. So I think Esther's proposal that support is the solution for those on the margins, and potentially indeed beyond for those who lack capacity, is very persuasive. It enables the person to remain an engaged participant, but it produces a new form of reliance on an advocate type role for a person who can support, to interpret and act in line with what the person wills or would prefer to happen. And so we can say, I think, that decision made is still recognizably the person's decision. Now, I think Esther's proposal to place the family as central supporters in this model is also very persuasive. There is a tendency sometimes in debates in ethics and law in this area to pitch Western autonomy versus Eastern familialism or communitarianism, such like. But as Esther suggests, autonomy is relational, almost by definition for me. And so we enable autonomy by capitalizing and engaging the existing trusted relations that people have. In Singapore, where existing relational frameworks for providing decision-making support in a healthcare context typically involve family involvement already, we have family members as natural supporters, people who can take on this role. But that, I think, will, as people have suggested, involve recalibrating the familial expectations and norms. This is not substituted decision-making. This is not about the family's values. It's about the family as advocate, as the person who can support the ability to enable an autonomous decision to be made through a network of engaged interactions, communications, and excavation of the role of the person. And just as importantly, I think the person needs to be front and center in that support activity. So I'll just finish with some conceptual challenges and then wrap up my comments. And Esther's really laid out many of these points already. I think we have to think very carefully and practically about what it actually means to be a supporter and provide decisional support. Cognitive prosthesis is an idea that's been developed in the philosophy of disability. It's this idea of sort of almost entering into someone's mind and being an extension of their mind. Well, that's a nice idea theoretically, but I have to say, I think for people with more profound impairments, it's a little bit uncertain how it actually works. What do we do in the absence of natural supporters? Do we have a series of advocates within an institutional setting who step in to support decision-making role? And how do we make sure that the supporter engages correctly and appropriately with those who have strict legal powers under the MCA to make substitute decisions? We have to recognise that we're working here within a framework where capacity or no capacity is still a fundamentally legally required judgment. But we're at the margins. So how then do we apply supported decision-making at the point at which we can work around fluctuations almost on a daily basis in the kinds of support that's needed? I think support will have to be dynamic and intense. It's a skilled role that involves carefully following and navigating the person, not just in terms of their values and their preferences, but also in terms of how their illness, disabilities, impairment change on a very day-to-day basis, how we communicate, how we engage, how we get to know them truly and personally. And finally, what does it mean to really focus down on the person's will and preferences? And if the person has more significant cognitive impairments, how do we avoid relying on previous statements rather than engaging with the person in terms of their current preferences? Because one of the important points about the supported decision-making paradigm legally is that it really emphasizes the current preferences that a person has over their previous values, which is something that the Mental Capacity Act requires us to balance. And we also have to be very careful here, as Esther suggests, that we don't deviate from norms of consent. If we start having a different standard for supported decision-making, where we're acting on the basis of a person's preferences, we're looking for things like, are they happy or content with the decision? We risk potentially engaging a preference and saying the person can give permission for making this decision, even if they formally lack capacity to make it. So we have to be very careful, I think, that we don't introduce a second standard for consent in supportive activities of these kinds. So I think when it comes to implementing this, there are regulatory questions open to us. Is the NCA fit for purpose in its current formulation to allow supported decision-making to gain traction? Do we need to recognise supporters more formally within regulatory requirements? How do we, at the systemic level, harmonise an approach through training and education and the formalisation of particular family members potentially, or advocates as supporters in that process? What does it mean to establish national guidelines? How do we audit for appropriate support and the configuration of relational-based approaches to autonomy? Lots of work to do there. How do we identify those who sit at the margins? When does one go into the marginal zone? When does one leave it? How do we recognise the scope of people who come under view here? How do we determine and engage the person who has been identified as the supporter? How do we document the required support plan? And how do we improve communication routine between supporters, professionals, and patients? And finally, I think there's important work to be done here. I think the real strength for Esther's proposal is this idea that it trades off a very localized set of existing commitments to familial orientations towards decision making. It tries to accommodate some pretty radical ideas into the existing legal framework that Singapore has endorsed, and it tries to build momentum by starting with the local marginal group of people who are perhaps the easiest to identify as in need of support. But I would suggest that there's the opportunity to grow in the future, including supported decision making, even for those who haven't got capacity and are otherwise having substitute decisions made for them. Thank you very much, everybody.